Top Med Talk.
Good morning and welcome to the EBPOM USA 2018 Fall Meeting here in Chicago, Illinois. This is Evidence-Based Perioperative Medicine's 20-year anniversary of delivering high-quality content to providers all over the world. So happy birthday, EBPOM. I'm Desiree Chappell, lead anchor for Top Med Talk, and I'm delighted to be sitting down this morning at EBPOM to discuss a topic that I am very personally passionate about, enhanced recovery after surgery. I feel like this weekend here at EBPOM we've offered not only the preoperative optimization track like we did at Atlanta, but we were able to add in a whole management track for perioperative care, really with a focus on enhanced recovery and some of the principles from that. And as a side note, today we're actually offering a third track for cardiopulmonary exercise testing. So that's going to be interesting to hear from the UK and the perspective on that. So no lack of amazing content, and really sticking with that theme of high quality world authorities presenting here to providers all over the world. So I am delighted to speak with my two special guests this morning and presenters from yesterday's session. We have Dr. Stefan Esper. He is Assistant Professor of Anesthesia and Director of Perioperative Services at the University of Pittsburgh School of Medicine in Pittsburgh. And we also have Dr. Jennifer Holden Murray. She is the Vice Chair of Quality Integration, Assistant Professor of Surgery in Division of Colon and Rectal Surgery at the University of Pittsburgh Medical Center as well. Guys, thank you so much for sitting down with us. I know that it's been kind of a busy meeting and you had a great session yesterday, so thank you for all that good high-quality content like we talk about. So I personally loved both of your presentations, and when we were talking about developing the EBPOM program and this track, one of the important aspects that we thought we needed to cover was not just about, enhanced recovery and some of these principles in a broad, high-level scale, but we wanted to dig down deep and get into the weeds of how we actually make something like this work. It's a huge quality initiative program. It takes a mass of people, and it's difficult to do. So, Stefan, yesterday, your presentation, you were talking about creating buy-in and sustainability, which is a hot topic. I get asked that question every day. How do we get people to buy into this, and how do we get all the providers touching that patient in the hospital to buy in? So I just kind of want to start there. Give us first a little bit about your background, how you got involved with the enhanced recovery at the University of Pittsburgh, and then let's just kind of do a deep dive.
Well, first of all, thank you for having us here on the podcast. Jen and I really appreciate it. The initial involvement with the enhanced recovery after surgery protocols at the University of Pittsburgh started in about August 2014 when I was brought up, kind of made aware of it by one of my colleagues from fellowship. And we had talked about it, Dr. Robert Thiele, and was discussing it with him, and then after reading the literature and discussing it more and more, went to our chair, and no one at the UPMC really heard of enhanced recovery after surgery, and after kind of getting the quote-unquote green light, as it were, not any time, but just say, go do what you want, and if you think you can improve, that's fine. I actually was then hooked up with Dr. Holden Murray about a month later, from the Department of Surgery, and that kind of created that relationship. There was somebody else who was interested in it. She can tell this story herself, where she was looking for an anesthesiologist to do this kind of thing, and we ended up finding each other and then moving from there. And one of the things I can say with regard to the buy-in and sustainability is it's impractical to think that any departmental or hospital administration is just going to give you the resources for some program like this that so bucks the general trend of medicine, especially for the last 50 to 100 years. And one of the most important things is to realize is that time generally has to come from you. That time came from us working full-time clinical schedules, and we spent all of our free time on this project for the 9 months, creating the protocol, really going on a road show to the people, finding those other individuals who would believe in us. And the initial cases that we did were accomplished by Jen and I. Rather, I should say Jen and me, forgive my grammar, okay. Where she was the surgeon, I was the anesthesiologist. We worked together in the operating theater, and then that's how it started. And then small teams developed until we had enough data where then the entire surgical department was interested. But I think one of the most important things to realize is the impracticality of asking for resources and time for something that no one trusts if they don't have the data coming from their own institution.
Yeah. And that is such a familiar story. I mean, everywhere you go, you get these small teams starting off and, it's like, oh, do you have an ERAS coordinator? You're looking at them. And I'm doing full-time clinical work too. So I know that there are a lot of challenges like that. Jennifer, I heard you yesterday talk about that many of these programs start from kind of that grassroots, just a couple people really interested in it. So can you give us a little bit of a background about yourself, how you got interested in enhanced recovery and your perspective from this?
Sure. Well, again, thank you for having me today and for the whole meeting. Where I started was I was first exposed to enhanced recovery after surgery in my fellowship training at Mayo Clinic, and it was relatively novel there. Not all of the faculty actually used it within colorectal surgery, but I really saw a dichotomous care approach and dichotomous outcomes in these two patient populations. And so I was a true believer. And so luckily, eventually, Stefan and I were able to find each other amidst the many masses of people and physicians at UPMC and develop this program. To speak to your comments about grassroots efforts, I think that's what it has to start at. If you try to really change culture of how we've cared for patients from a top-down approach, it's very difficult. And so where I think everyone can have a real meaningful experience is finding your core champions. And you need a champion in a lot of different specialties, not necessarily surgical or anesthesiology, multiple specialties, but nursing, floor nursing, PACU, pharmacy, IT. You really need to find a core niche of people that you can recruit and believe in your cause, and then you'll have better outcomes. If one of those people that has constant patient contact in your team doesn't believe, the whole process is thwarted. So you really need to find that core group. So where we started was grassroots with finding this core group of people, nursing, primarily our clinic, my partners within the division of colon and rectal surgery. They weren't believers, but they were willing to try initially, and they all became quick believers. And then after the grassroots efforts, then you go out and publicize. And it doesn't have to be a lot of data. You just have to show what you're doing. And from showing what we were doing, we were able to then grow our program pretty rapidly because everyone wanted to really be on this bandwagon of, hey, look at their outcomes. They've had a huge length of stay reduction. And wow, that equates to a big cost savings. And so once you start getting the dollar sign cost savings, then more people start to listen to you.
Yeah, for sure. One of the things I always recommend to people to get buy-in, especially from surgeon anesthesia providers and nurses, is just to go up and look at these patients. You kind of know what a typical patient looks like, in bed, misery, not eating or drinking, starving, the whole deal, to the enhanced recovery patient who is bouncing around the nursing station, getting their steps in, excited to go home, right? And so I think that it speaks to that whole creating that sense of urgency, but creating, engaging and getting people excited about this really does make a huge difference.
Absolutely. You can't walk away. You have to really if you only have a few nurses that are really believing you and maybe the nurse unit director for the floor, you want all of those other nurses to go and see that ERAS patient and say, hey, that's an ERAS patient. You want everyone to keep pointing that out and talking because you have to be in their face to get everyone to change. And if you don't get the floor nurse or the clinic nurse to change, you're cutting yourself at the ankles already because they're there telling your patients, oh, you need these opioids or you need to lay in bed and you should just lay there, or that's not the message that you want to portray.
And, along with that, the reason why the champion is so necessary from all aspects is because the general time it takes for a culture change to occur is not days or even months or even a year. The cycles, at least from the business literature, and I presented a significant amount from the business literature, are anywhere between 5 and 10 years for an actual cycle of generational change to really take place. And so to solidify these protocols, the generation coming up has to have embraced them. And Jen has said that, yes, this is somewhat of a change in medicine because we are bucking the trends that have been traditional. And I'd like to add to that this is also really more of a change in culture. more than it is a change in medicine, because it's that culture of thinking, the culture of understanding what truly is the best for the patient, perhaps those traditions that we have taught, and we're still really teaching now in residencies.
It never stops.
It doesn't stop. Perhaps they're incorrect. And the data that's coming forth really speaks to that. But again, it's that cultural drive and that change in organizational behavior. And by what I say organizational behavior, not just my hospital or our hospital system, but your hospital system, the nation's hospital system, Britain's hospital system, which is already done, the national health system. So Dr. Keelat, I think, was doing these programs in 1997.
Yeah.
And that was, 21 years ago.
Yeah.
And how long did they take to take off? And, we're here at the end of 20 years, and I don't know how long it took to take off in Britain or some of the other countries, but we still have that generational gap to fill within the United States. That's what it looks like to us.
Yeah. We could go so many different directions with this conversation. One piece that I think that is important, so 2 points. One is I was thinking about this. Have you guys changed at your university the way that you're teaching your residents and incoming providers, nurses, about enhanced recovery? Have you been able to get to that point yet?
Absolutely.
Yeah.
So we make it a point to educate, especially all the onboarding, all the units, the patient care units, whether that is a PA, a mid-level that's on that unit, or nursing. And then we onboard all new staff, too. We have refresher courses for the old staff and new staff onboarding. And then for the residents, they are exposed to it now from day one. Most of their service lines are doing enhanced recovery after surgery, and so this new generation will be exciting to see what they can do next.
Yeah. So one piece I get is that, when we first start this, everybody's excited, and you can start these big education, blitzes, as I call them. But what happens over time, it takes a lot of bandwidth and time from, you guys as organizers and coordinators. If you don't have someone specifically dedicated, how do you make that happen? How do you continue the education? Because I really feel like it's whenever you stop and let your foot up the gas when it comes to making sure everybody's on the same page and continue to deal with turnover and other things. How have you guys done that in your facility without having an enhanced recovery coordinator? Because you didn't have one for a very long time, right?
We did not have one initially. We developed several techniques. We made up awards that we gave out, ERAS All-Star Awards, where we honored nurses or mid-level providers who were great at educating their colleagues or really the champion, and we publicized this. We encouraged all of our multidisciplinary team to present. So whether it was a nursing forum that was local for the hospital, whether it was for the entire University of Pittsburgh Medical Center system, or more nationally, we wanted them to get out there. They presented data, and then we displayed their posters back outside of the OR or in areas where everyone would see, so we could continue to publicize the results. So I don't think it's just about education, but you want to keep sharing your outcomes so that people keep believing. Because just as you said, your outcomes will start to degrade. People will slowly revert back to their old way of doing things because it's not really ingrained into them yet.
Yeah, that dogma is strong.
And to keep people really interested, there is a topic that I mentioned in the conversation yesterday called empowering leadership. Yeah. And this is not specifically empowering the leadership, our hospital administration, but it's how do we, as the leaders of the Enhanced Recovery After Surgery protocols or the Center for Presurgical Care, how do we empower others on the team to buy in and to be committed as a champion to that team? And that's a very important concept because there's a significant psychological component to that. Yeah. And too often in medicine, let's face it, there's a significant amount of ego that goes around. And we end up delegating these specific tasks, but they don't carry the interest or the want to do those tasks for our team members. And so it's about sharing the tasks that everybody has a joint commitment to. And really not expecting anything from anybody else that you wouldn't do yourself or that you haven't done yourself. And I think one of the reasons why Jen and I have been able to continue to get buy-in is because we did it and we're still doing it. I think that if folks see the captain scrubbing the deck, they're going to want to scrub the deck too, if I may use a very crude naval analogy there. But I do think that is specifically important. And that isn't necessarily always common in the medical field.
Right.
And I mentioned yesterday Howard Schultz as the CEO from Starbucks, who didn't just sit in headquarters. He went and he saw folks at the stores, and he spoke to the store clerks, and he spoke to everybody on equal footing, and everybody was equal because we're all equals, and got the ideas from everybody, and developed many champions in that.
Yeah, I loved what you talked about yesterday, and I could totally relate to it when you were saying that, you talk to people and successes were great. We can all share the successes, but you guys were willing to take on some of the when things failed or didn't go the right way. It was like, oh, yeah, we totally get it. Kind of take that upon yourself, not place blame on anybody, not try and degrade the program by talking about that, but you were able to combat some of the dogma creep by kind of taking that on head on.
Jen, I think that we would both agree, and I'd love for you to speak more on this, but I think that accepting the failures is really defense of the team. To let the team know that we will defend them.
And then when you have that failure, it's an obstacle, and you find a solution right away. So you can't just let the failure continue and persevere because everyone keeps talking about that. Find a solution right away and be involved.
Yeah.
Obstacles are reasons for solutions.
Yep. You said that yesterday, and we've heard that continuously actually through this entire through the meeting. I mean, that's a common theme, and I think that those of us that are in the trenches doing it every time, doing it the whole time, I think that's a hard lesson to learn, but we're learning it. I also say, too, that overcoming some of those obstacles, some of the best innovation to do that comes from those people that are doing it, all the time. So, like I said, I could talk to you guys forever about this. I really, really appreciate you sitting down with us. I think what you guys talked about yesterday, creating buy-in, sustainability. Jennifer, you talked about the internal marketing piece and external marketing, which I think is huge. Again, kind of continuing to create engagement and keep people excited is a really important topic that we're going to be discussing a lot more as we go forward implementing enhanced recovery. So I want to thank you again so much for joining us. Hopefully we can do this again next time that we see each other. And thank you to everyone listening out there. We are still going to be live streaming from the EBPOM meeting throughout the rest of the day. If you missed it, we're definitely going to be putting lectures up over the next couple months and sharing with you what we were able to hear this weekend. Be sure to follow us on social media, your favorite platform, Facebook, LinkedIn, Twitter, as well as subscribe to Top Med Talk. Thank you so much for listening. Have a great day.
Top Med Talk.